Hey guys, welcome back to the I Believe podcast. I'm Danae, and I am back here with Dr. Zachary Berman from the University of California, San Diego. And we're going to chat a little about Hepzato Kit, which has been FDA approved now for, I think, about 2 years. It was like 2 summers ago is when it was FDA approved. But before we get into that, Zach, do you want to tell me about these incredible photos behind you? Because I'm like totally awestruck.
Yeah. So my day job is interventional oncology, but I guess my night and weekend job is imaging. And so these are photos of the Andromeda Galaxy and the Horsehead Nebula that I took on through my telescope.
It's absolutely incredible. I love photography, and this kind of, like you said, it's called astral photography.
Exactly. Yep.
It's so cool to see. My kids would go nuts. They're always wanting to look at the stars and look for comets and like that kind of stuff.
Yeah, it's a real test in patience. I wish them luck.
I believe it. Okay, so like I said, guys, we're here to talk about Hepzato Kit, its role in treating liver metastases, and the latest in what patients need to know. Just as a reminder, we're here to give you information to help you develop like an informed opinion and to basically better advocate for yourself. Please make sure to seek personal medical advice from your doctor and use this episode again, like just as a simple way to learn more about Hepzato and to be your best advocate. For the purpose of this episode, I'm going to kind of play the part of a metastatic patient who's been told, Hepzato's on the table. And Dr. Berman is going to just kind of play that role of like, okay, he's explaining to you or me or all of us as though we've never heard about this. So bear with us. But can you just explain, when in a metastatic journey, like why would I be coming to you, I guess, as a uveal melanoma metastatic patient?
Yeah. So ocular melanoma is a very interesting and obviously a very rare disease. And for whatever reason, I don't think we fully understand why. It really likes to go to the liver. It's usually the first place it metastasizes. And most patients over the course of, their cancer journey will eventually end up with liver metastases. Some series it's up to 80% over 10 years. And so most patients would have usually had their initial primary cancer treated maybe a couple years in the past or so. And they were getting their routine scans, or maybe there was an elevated test on one of their routine blood works. And all of a sudden, there's now liver metastases. And that's usually when they'll come and at least have a discussion with me. I work in a shared clinic with our melanoma oncologists. And so usually they'll see both of us together and kind of create or formulate a plan for what we think might be the best way to tackle these tumors.
For the sake of this discussion, I've got maybe 1, 2 kind of larger-ish, 1 or 2 centimeter lesions. And I have a couple of those, what they call like satellite lesions around them, right? I joke that it's like we've got the mothership and then we've got all the little stars or the little babies around it. Why would that make me a good candidate for like Hepzato as opposed to maybe something else that interventional radiology might do? Like, because I've had like a microwave ablation before. Like, why couldn't I just do that?
Yeah, of course. Unfortunately, because it is such a rare disease, it is really hard to do large clinical trials where we kind of examine every single patient scenario and say what would be the best option. So, for the most part, a lot of what we're doing when we see new patients is kind of saying, this is our best medical judgment. We can look at other sorts of, cancers that metastasize to the liver, like colorectal cancer or pancreatic cancer or something like that, and say, these are the sorts of options that we tackle, and these are the options that we have. Now, if you had a single tumor, like you mentioned before, it might make sense that we should only need to treat that one single tumor with something like a microwave ablation or any of the other ablative technologies that are out there. Unfortunately, what usually is the case is maybe you only see one on like a CT scan, but then you get an MRI, which has better resolution. You might see five, six, seven, and sometimes many, many, many more tumors throughout the entire liver. And when that becomes the case, if you imagine doing a microwave ablation and having to treat every single one individually, you would have no liver left. And so you can't really get rid of the entire liver. It's called the liver for a reason. You need it to live. And so you just can't get rid of it all. So now you have to start thinking about different types of therapies that you can do to the entire liver to treat all of the tumors that you're seeing and many of the ones that you're probably not seeing because they're too small to be seen on a CT or an MRI or a PET scan at the same time. And for a while, there was a lot of different therapies that were given, and usually when you're at this scenario, it's what we call transarterial therapy. The liver is a very unique organ where it has a dual blood supply. What does that mean? Well, if you think about your brain or your heart or your kidneys, there's usually an artery that goes into it and a vein that drains it. In the brain, it's the carotid artery and the jugular vein. In the kidney, it's the renal artery and the renal vein, and in the heart, it's the coronary artery. I'm sure you've heard of all of those, bad things that can happen inside of them. But the liver is unique. It has not only an artery that goes into it, but a vein, the portal vein. Portal vein drains all of your intestines and drains all of the nutrients and everything back to the liver. But interestingly, while it goes to the normal liver cells, it doesn't go necessarily to a lot of the cancer cells. Actually, very little of it actually will go to the cancer cells. The cancer cells, in turn, get most of their blood supply from the artery. And the background liver only gets about 20% or so of its blood supply from the artery. So we can use that to our advantage where we can put something into the artery that goes to the tumors preferentially and less to the background liver. Not 100%, but less to the background liver. And there's a whole bunch of different things that have been kind of experimented in the past with like chemoembolization or immunoembolization. I'm sure you've heard in the past for uveal melanoma. And again, those are different sorts of agents that we can give either chemotherapy or an agent to stimulate your immune system like GM-CSF to really go and fight the cancer. More recently, as we were mentioning before, this concept of intrahepatic or percutaneous hepatic delivery of really strong chemo agents called melphalan has gained a lot of usage over time. And, it's marketed on the market now as the Hepzato Kit. And the reason why it's called a kit is the melphalan itself is quite toxic. It's an incredibly powerful chemotherapy. It's what they actually give to get rid of your bone marrow before you get a bone marrow transplant, for instance. And so we obviously don't want to give you a bone marrow transplant if we're trying to, cure your or treat your uveal melanoma. So at the same time, too, we have to filter the chemo out before it goes to the rest of your body. And that's what that kit does. And I'm sure, the whole ins and outs and nitty gritties has been explained on different podcasts. So I won't go into it. But essentially, the idea is put the really strong chemo that kind of fills your entire liver, but filter it out before it goes to the rest of your body.
Oh, so I love this and I love your explanation. But I also want to, like you said, like just refer people back to some of the podcasts that we've done before. We've had Dr. Padia, who's also in California, talk about Hepzato in multiple different ways. He's talked about it on the podcast, and he also was part of our liver directed, like puzzling out liver directed therapies on our Q1 webinar, I believe. And that was earlier this year in 2025. So you can find those on our YouTube channel. Feel free to check the show notes or the description below. We'll make sure to include those. So that aside, okay, back to I'm a patient. So you're my doctor now, like because we've decided, or it's been decided by this group of people, that I should have Hepzato Kit on the table. So I guess would I just come to you? Like, would I have just found you, or would my medical oncologist have to refer to an interventional radiology?
So it's a little bit of a mix of both, right? So not every single center, because it is a little bit intensive as far as resources. You need to have a certain type of anesthesiologist. You have a perfusionist. You have to have the right space. You have to have people who are trained in it. It is a little bit of a different procedure from an interventional radiology perspective. And so there's a lot of specialized training that goes into it. So only a few centers throughout the U.S. do it. Obviously, we're one of them. I would say some of our patients kind of find us, and then some of our patients we find internally just through our natural care network. I found it particularly rewarding if someone comes in from the outside to also have a consultation with one of our medical oncologists, because again, we do a lot of clinical trials here in the space as well. And so I think it's really beneficial to not only get the second opinion, but I think it's nice to have both a medical oncologist and an interventionalist in the same space to have a multidisciplinary and kind of more holistic approach to how it is. So if someone comes in from the community, I always offer them a consultation with their medical oncologist as well, just to make sure that they get a second opinion to make sure everything makes sense, or even as we go down the Hepzato journey, if down the line there's a clinical trial or something else that has come onto the market since then, they're always given the most up to date information.
Yeah, that makes total sense. Okay, so let's just say, for the sake of chatting, that I'm a patient who I've also got, like, I don't know, one bone met, right? I've got like one metastatic spot in my hip bone. Is Hepzato going to help me with that?
No. So the whole idea of Hepzato is that it doesn't get systemically, right? So we talked about how powerful of a chemotherapeutic agent the melphalan is. So the whole goal is to prevent as little as you can getting to the whole body. The numbers vary depending on who you ask, but it's usually less than 10% of the chemo that you're giving actually ends up getting systemic.
Well, that's insane. Like, that's a very small amount of chemo compared to, obviously, like, I mean, I think the stereotypical cancer journey says, oh, I got chemo, I'm going to have stomach problems, I'm going to lose my hair, I'm going to, have susceptibility to the sun. Like there's so many different side effects that can happen from chemotherapy.
Correct. And the inverse is also true. Since so little of it gets into your system, that allows us to really intensify the amount that we put in the liver, right? So there's always limits. There's different curves. The LD50 curve is something you may have heard if you, I don't know, Google this kind of stuff, where there's a certain dosage of the chemo that will kill the tumor, but there's also a certain amount of dosage of the chemo that will kill the background, normal tissues. And you're always balancing that, right, with any chemo agent that you give. The beauty of being able to filter most of it out before it gets to your entire body, the liver is actually pretty resilient to this chemo drug. So you can give a much higher dose without affecting the liver, which means that you can give a much higher dose to the tumors as well. So not only is it not going to go to your entire body, but you can give a higher concentration inside of the liver than you would normally if you were to get like an IV infusion of this.
Yeah, that totally makes sense. Hypothetically, I'm on Kimtrack or Ipi-Nivo. Like, am I going to have to stop that to have the Hepzato treatment? Because those are what my doctors are telling me is that's the stuff that's going to make sure that, the hip bone metastatic spot doesn't become like 20 billion little hip bone metastatic spots. Do I get to keep doing, I'm just going to say Kimtrack for the simplicity of it.
Of course. So let's take a step back and say, just because you have the hip bone metastasis doesn't necessarily mean that you wouldn't have a benefit from treating the liver disease, right? So let's say you have a 1 centimeter hip bone metastasis, you're probably not going to end up, having issues down the line because of that. Maybe you might have pain eventually or a little discomfort, but the liver, if you run into having too many tumors inside of your liver where it eventually replaces too much of your liver or blocks a bile duct or something like that, you could really run into a lot of problems. So whenever we have these sorts of scenarios, it really helps to have that multidisciplinary conversation and say, I really think the liver is what's going to get us into trouble in the short to intermediate term future. It really does make sense that we should treat the liver, even though there may be a metastasis outside of the liver. And again, that's something unique to uveal melanoma, where it does metastasize to other places, but it really loves to go to the liver. Now to the question you directly asked me, which is the systemic therapies. We don't actually know the answer to that question. So when they did the trial, the FOCUS trial, which is the phase 3 trial that got it FDA approved, they were just getting the Hepzato, the melphalan, in and of itself. There is an ongoing trial in Europe called the Chopin trial, which the first safety analysis came out where they were doing the combination of Ipi-Nivo plus Hepzato. And it seemed that it was safe. And in the early efficacy or how well it was doing seems to be encouraging. We're still awaiting the final results, and those should be coming out hopefully in the very short to near term future. And that'll give us a lot more insight as it relates to that. Now you ask about Kimtrack or tebentafusp. That's a little bit harder to know. We definitely have treated patients in the combination with that. But again, we don't have any clinical trial evidence to say it's a good idea, it's a bad idea. Mechanistically, the immunotherapy works functionally different than the chemotherapy melphalan does. So mechanistically, it makes sense. But again, going back to what we were talking in the very beginning of our conversation, a lot of the stuff we're not going to have clinical trials for, and it really is going to be kind of a multidisciplinary discussion, kind of with everybody, right? So you have a medical oncologist, you have the interventional oncologist, but more importantly, the patient's going to be involved in this as well. So we would meet with you in clinic and say, we don't really know what's going to happen. We don't have, phase 3 evidence to say this is definitely a good idea. But in our clinical experience, our rationale, these are the side effects. We think you may derive a benefit. What do you think? And then you're obviously part of the decision, process as well. And your input could be at the same time too, where you could say, it seems like too much. Or I have other patients who are like, can't we just do Ipi-Nivo, tebentafusp, melphalan, immunoembolism? Let's just do it all at once, right? Do everything. But, so it's a patient by patient kind of discussion that needs to be had.
No, I think that makes total sense. And I'm just going to interject my own real life experience here to just say that I did choose, after having this discussion with my doctor and with the interventional radiologist here in Arizona, I did end up choosing to have an immunotherapy, just kind of going off of the hope of the Chopin trial from the UK, which, like you said, that's coming out sometime. I think in the fall is what I've heard noised about. So hopefully we'll hear soon. But I did choose to do that. The downside for me, at least, was that the immunotherapy that we chose ended up stimulating liver hepatitis, autoimmune hepatitis. So that obviously wasn't great. My immune system decided to attack my liver, which in theory could be, my doctor's over here like, well, that could be good, right? We stopped it, we got it under control, but also like we turned your immune system on really well. So that could be a good thing. So, and I appreciate, having that kind of hopeful thing to think about, but I digress.
Castle Biosciences is a proud sponsor of this I Believe podcast. Castle's innovative uveal melanoma tests provide valuable information about the risk of your eye cancer spreading to help you and your healthcare team individualize the management of your disease. To learn more, visit castlebiosciences.com.
Back to I pretend I know nothing. Okay, so I think I'm on board. Like I think I want to have the Hepzato treatment. What do I need to expect like from the treatment days and kind of like, how often do we do this?
Yeah. So if we look at the focus trial, which is really how this all got started, it was up to 6 cycles, and each cycle is each treatment. That's what we kind of call it. I think in the trial, most patients got about 4. And in our experience, sometimes PAH patients need 4, sometimes they need less. But you would come in for a procedure. So just like any other, surgery, you wouldn't eat the night before. You'd come into a preoperative area. You'd meet the anesthesiologist. Some patients have to get a cardiac workup before you might get a echocardiogram of your heart or an EKG, just depending on your other medical factors. You come in for your procedure. It's always done under general anesthesia, so you'll be completely asleep. Then, without going too much in the nitty gritty, because you have the previous episodes, you would have the Hepzato procedure done. And then I think most people now are recovering in a what we call a short recovery unit, where you would spend the night in the hospital, but it's usually not necessarily like the inpatient side of the hospital. At least for us, we have it called the rapid recovery area, where it's not like you're in the hospital floor. It's just a separated area where you're expected to spend less than 24 hours. So most of our patients have the procedure done by noon or 1 or 2 p.m. You're eating, you're walking around, and then you spend the night in the hospital, make sure everything's okay. And the next day you go home. We usually check in with you every couple of days afterwards, just to make sure everything's okay, seeing what your side effects are. And then about a week or 2 weeks later, our current practice is to get a blood draw to see what your white blood cell counts are doing, because I know some patients can have some decrease in their white blood cell counts afterwards. Based on that, then I see, I let you live your life for about a month or so, see you in clinic, thereafter, see how everything is going. And if you're up for it, we'll kind of get another one scheduled. Our cadence is every 6 weeks to 2 months. And then every 2 months, we'll do that. After the second cycle, we'll usually get our first, what I call the report card, where we'll go back in and rescan and see how things are going and make future treatment decisions. Again, in a combination with you as well as the medical oncology team.
Okay, I think that makes sense. I've kind of heard some noise from other friends who've had this procedure, and they've just said that, especially the first time that you have the Hepzato treatment, it can kind of feel like you've been hit by a bus. I mean, is that something that I should expect as well? Like just physically to be pretty knocked out for a bit?
Yeah, so it is a big procedure. You're under general anesthesia, so you don't actually feel any of the procedure as it's being done, but you're getting decently sized tubes put into 3 veins and 1 artery, and there's a lot of fluid shifts happening as the blood is being taken out of your body, filtered, and then putting back into your body. So there's just a lot happening, and during the procedure, there are some physiologic changes at different parts as you're going on the pump and coming off of the pump, and so it's just a lot of just fluid shifts and stuff like that, and so it really can kind of knock you out. And like you said, a lot of my patients say they got hit by a bus, right, for the first couple of days afterwards. The good news is the first cycle is usually the worst because you're not knowing what to expect. But after that, it doesn't like become cumulative where each cycle gets worse. It's all the same, and usually once you know what to expect and how to plan for it, you're usually in a pretty good place for it.
Yeah, I think that makes sense. And I mean, I've had like liver surgery before, so I mean, that knocked me out for a solid 6 weeks. So hopefully this will be a little less than that.
It's definitely way less than liver surgery, I'll tell you that.
Yeah, for sure. What about the whole laying flat thing? Like I've heard of chemoembolization and like immunoembolization, and they always talk about how hard it is to have to lay flat. Is that something that happens across the board, or does it kind of depend patient to patient with you, with like how you guys do this procedure?
It's going to be center to center because every center has their different kind of techniques for how they do it. We reverse the anticoagulation that you have during the procedure, so you're back to a normal coagulation limit by the end of it. And we also have techniques for how we kind of close the little holes that we made in the arteries and the veins. So all of our patients are ambulatory within 2 hours. And so our goal is to get you walking as soon as possible. Now, there's a lot of stuff happening. You're still waking up from the anesthesia. You might want to eat a little bit, kind of get re-equilibrated after.
Acclimated.
Yeah, exactly. So you may not be walking, but our goal is to get you walking definitely the same day and as soon as possible.
I think that makes sense. So you mentioned, as far as the other side effects, not just like in the hospital, things to expect. I'm just recapping, like the white blood cell count drop, platelets down just because of anticipated blood loss. Would I like always need a blood transfusion for like, I guess, what is it? Like just bags of blood? I know like some people say they have to go to the ICU for this procedure and they have to have blood. Like it's always going to happen.
Since we take all of the different, we call them sheaths, or the little tubes that we put into the arteries and veins out during the procedure, none of our patients go to the intensive care unit afterwards. They all just go to this rapid recovery area and spend a night over there. We don't give very many blood transfusions. Most patients come in with a normal level of hemoglobin, or the red blood cell count. And even though you do lose a little bit of blood during the procedure, it's not a lot, and not enough to require a transfusion. Occasionally, and it's usually not the day of or the next day, but it's like a week or two later, if your white blood cell count is quite low, we call it neutropenia, you may need to have a different type of medication given to kind of boost how much your bone marrow produces your white blood cells. So that might be an additional medication that you might need to augment how much, your bone marrow is producing.
Aura Biosciences is a clinical stage biotechnology company focused on developing precision therapies for solid tumors that aim to preserve organ function. Our lead candidate, Belsar, is currently in late-stage development for primary choroidal melanoma and in early-stage development in other ocular oncology indications and bladder cancer. Our mission is to grow as an innovative global oncology company that positively transforms the lives of patients. For more information, please visit us at aurabiosciences.com.
Okay. I think that makes sense. As far as like the procedure goes, that seems, as straightforward as, I feel like I would explain this to somebody and they would say, that sounds like so much. But also, like you said, it's not as much as liver surgery. It's not as much of a recovery time. So to me, this sounds great. You mentioned a little bit of kind of a check mark with like a report card on the imaging of checking in after 2 treatments. So like this is an image-based procedure, right? You use an angiogram to like visualize where you're going. That's why interventional radiology is needed. So why do we still need scans? Like I
Yeah,
hate scans.
of course, yeah. So, if we were to look at the FOCUS trial, not every single patient responded to this treatment. Now, I think in our collective experience, since it's been FDA approved and we've been doing more of it, I think we're seeing better results. And I don't know if that was just how the patients were selected for the FOCUS trial, or weird things can happen when things are in a clinical trial because of how regimented it has to be. But in the real world, when we're a little bit more free to kind of choose the patients who need it and image at different time points, et cetera, we're seeing that patients are actually responding at a higher rate. And the only way you're going to really know that is to take a look at the liver. Now, theoretically, you could get one of those angiograms to see what's going on in your liver, but that's an invasive procedure, and it requires, you being in the hospital and having stuck in the artery and taking pictures versus an IV and looking at your liver that way. So it's also cheaper to do it that way. And so anything that's less invasive and cheaper, I think most people would agree is probably the best way of doing it.
Okay. I think that makes sense. I guess I will go in the MRI tube. It'll be fine. So listen to music and get through it. Thank goodness it's not too long these days. What about like blood tests? I've heard a couple of patients talking about how like their doctors are all doing, like I think in Wisconsin and like some people on the East Coast, like their doctors are doing a ctDNA with like Signatera or something similar. How do you see that as something that we could use? Is that something you use with patients like these days?
Yeah, so ctDNA is like one of the hottest topics in kind of tumor marker space these days, not only with melanoma but other malignancies as well. The Bentifusp trial that got Kimtrack approved for the FDA had that as one of their endpoints, where they were looking at the percentage reduction in your ctDNA, or circulating tumor cells, DNA in your body. I don't really know what to do with those numbers. I think going down is good. I know 0 is, or undetectable is the best, but let's say it's going down but not 0, but we don't see anything on your MRI. I don't have the knowledge to know that we need to continue treating you with this invasive procedure, or if we can just take a look at things and see how things are going. So unfortunately, in 2025, our best biomarker, or something that tells us like what we should be doing, is imaging. However, as we are starting to get more experience with stuff like circulating tumor DNA, I think in the future that's going to play a much bigger role. And who knows, maybe in 2030 when we're doing the same podcast, I may have egg on my face because they're going to be like, yeah, everyone needs to see.
Yes, be here, be back in 5 years, guys. Be back. Seriously, I will. I like the idea, obviously, of a blood test instead of an MRI, but like you said, it makes sense that we can't necessarily use it alone quite yet because it's still developing, still getting better. So moving on, I have, just some concerns. A lot of people kind of noise about, or maybe they just wonder, like, okay, you're giving chemo to the liver. Like, is that going to cause liver failure or like cirrhosis? And maybe like define what cirrhosis is, because I think not everybody knows what that is.
Of course. So cirrhosis, all it really means is that it's causing scarring of the liver. And there's different forms of that. And fibrosis, or the fibrous bands that kind of form within the liver, have a staging score. There's a lot of different ways that you can end up with getting cirrhosis. I think most people think it's like hepatitis or alcohol. Actually, in the US right now, the leading cause of cirrhosis is actually obesity, or fatty liver disease. Is becoming a huge problem. But the other way you can also get it is you might hear of some people on chemotherapy getting it, and that some people call it pseudocirrhosis. For me, it doesn't really matter. There's the scarring inside of the liver. It's the same physiology. For those patients who are usually getting it, it's years and years and years of chemo. It's usually not the patients who are getting short little bursts of chemo, like you would with something like Hepzato, where you're only going to get it 4 to 6 times. And so even though you are kind of saturating the liver in chemo, it's not that continuous exposure, and the liver has time to kind of like regenerate in between. Now, if you were to get Hepzato 20 or 30 times, you may see some of those changes down the line. But at least where we are right now in kind of current clinical use, we're just not seeing it.
Okay, well, that makes me feel better because I just know, obviously, you talked about this. The liver is something you need to live. Like, so we really need my liver to be working and not have, potential damage to it. So that's reassuring. Why do I need to do it now? Or why would it be better to do it now while I have like kind of what looks like my oncologist said, it's kind of a smaller disease burden, right? I've only got a little bit, like maybe, I don't know, 5-10% of the liver is involved. Why do Hepzato now as opposed to waiting until like there's just more going on in the liver?
Yeah, that's the $1 million question, obviously, the timing of when to do all of this. So what do we know? We know that the more you have in your liver, the worse you do. 25 to 50% versus 50% or greater have very different outcomes. And so our goal is to prevent you from ever becoming the greater than 50% of patients. And so if you have a solitary lesion, I think we would start talking about ablative techniques, right? But if you have 4, 5, 6, 7, 8 tumors, even though it might only be 25 or 30% of your total liver, I think we still are in the realm of let's prevent those from getting to being more of your liver, but we still can't do ablation per se, or surgery or whatever. Yeah, so that would be the rationale for why to do it. And again, this is where the art of medicine comes in rather than the science. Sometimes it's really difficult. And some of our patients, they don't want invasive procedures. They would rather just get the MRIs and pull the trigger on a procedure when it absolutely is needed. And again, that's where the discussion with your physician about what's the optimal thing for you in the absence of randomized clinical data.
My last question, as far as, maybe myths and things that we could bust here. I work with an integrative oncologist or like a naturopath oncologist. He's got me taking, various different supplements. We do the occasional, I don't know, like an IV vitamin C. And, occasionally we do like ozone therapy. Are those kinds of things something that I have to stop in order to have Hepzato? Or is there, room for me to continue doing those in between, because like you said, this is every 6 to 8 weeks.
Yeah, in general, I ask my patients to stop it just because I don't know what's going to happen, right? So when they do these clinical trials, a lot of the conventional medications that you talk about are recorded and documented, and it's all reported as part of the clinical trial. These patients had these medications and it's safe. So when it comes to like herbal supplements and kind of over-the-counter supplements and stuff like that, it's really hard to know exactly what to do in that regard. The other issue becomes a problem is that it's not regulated as closely. So even though the bottle might say 200 milligrams of milk thistle or whatever, it may be 20,000, right? And so maybe 200 is actually fine, but 20,000 wasn't. And so rather than taking the risk, I just ask, can we just stop it while we're doing the therapy, just to be safe and abundance of caution.
And I mean, like you said, like this is 6 to 8 cycles, depending on who you talk to. Like, so it's not like you're stopping this forever. It's just temporarily like taking a break, kind of scaling it back. Then I think that makes sense. Let's just chat a little more about the future of Hepzato. And like we've mentioned clinical trials, you mentioned the Chopin trial or Chopin. I don't know how we say it.
I call it Chopin, or whatever that's worth.
Probably correct. It's probably correct. Where do you see the future of Hepzato heading, I don't know, in the next 5 years?
Obviously, in combination with other different therapies, it's going to be incredibly important to see, can it stack with, tebentafusp or ipi-nivo or any of the other medications that we're giving. It's also under clinical evaluation for other tumors that have metastasized to the liver, like colorectal, for instance. I think they just enrolled their first patient on the colorectal trial recently. And so we may have more different therapies for other types of cancer in the future as well. And then also importantly, as we gain more clinical evidence or real world evidence, we're going to start to see things. Oh, this worked. Oh, this didn't work, et cetera. And you're going to start to see publications about people's experience in the real world, so to speak. And that's going to kind of inform us like, oh, maybe we only need to do 2 cycles. And if you're having a response, you only get 2 cycles. Or maybe it's the opposite. Maybe it's even if you don't see anything, you need to keep going, right? So optimizing the number of cycles you're going to have and then even the frequency, right? Maybe you just get it once every 6 months. We have no idea, right? And so as we gain more experience, we'll have a better sense of those sorts of questions.
I think my favorite thing that I'm looking forward to learning, and I don't know if this is officially going to become an actual trial that they're going to be checking and testing, but I hope it is just for them to look at treating adjuvantly, right? Or, semi-adjuvantly, like where we have somebody who had a massive tumor in their eye. We know they're class 2, like high risk melanoma, like uveal melanoma patient. They've got the highest risk of Mets. And instead of saying, yeah, let's just let you sit and wait for the next 2 to 5 years and hope you don't get Mets, let's actually do something first. I think that what I heard was either they're considering an adjuvant treatment trial where they would say, okay, you're high risk. We're going to give you 1 dose of Hepzato and then just see what happens, see if we can kind of log any data from that.
I think that's incredibly interesting. Unfortunately, as you mentioned, or as we talked about earlier, most patients will develop liver metastases. The problem is it might take 5 to 10 years before that develops. And so if you're starting a clinical trial today looking into that, it may be quite a few years before
maybe a while.
Your data. It is, like you said, one of the most important open questions we have right now.
The level of personal frustration that I have with it, it's like you said, okay, we've got an image, right? We've got to look at the MRI. We're treating the tumors that we do see, but also the ones that we don't, right? We've got, like I said, we've got 7 tumors in my liver, but you're saying we have the potential that there's a bunch of other little ones that we just don't see on the MRI yet because they're too small. And you're saying let's treat what we don't see by treating the entire liver. So then I'm over here like, but then it may make sense to do adjuvant because we're just going to treat what we don't see. Anyway, so we'll just have to see where it goes, right? Like you said.
We're all in the ride together.
Yeah, exactly. Well, you guys, if you have any questions, please drop those in the comments below. We'll do our best to get an answer from Dr. Berman or just kind of forward that to him. Like we said, we can't give personal medical advice, but we would just love to answer any general questions that you have around this treatment or just around kind of maybe the places that you could have this treatment done. Dr. Berman, is that something that like where people can learn and like reach out for care directly? Like if they're not local to the UCSD area?
Yeah, I think there's a website from the company. I think if you Google it, you can probably find it.
Oh, yeah. I do have that. Sorry, it's in my notes.
And so put that in the description below. The company will very much help you not only find a physician that can do this procedure, because again, it is quite specialized, but more importantly, they've also worked with other companies to help get insurance approval, which is, a major limitation that a lot of people run into. And so they can help you with the insurance aspect of it as well.
Okay, and just for my notes, that's the Hepzato Access website. So if you search hepzatoaccess.com, and again, I'll put it in the show notes, it'll go into the description, then that's going to make sure that you can find centers that actually are doing this. And the nice thing is that you guys, Delcath has been so hard at work at opening these centers and finding places. I know like we have an area in the Phoenix area, but we've had representatives out here like kind of scoping and panning the hospitals and looking for like, okay, who else can do this? Because this is going to be such a promising procedure for of course, uveal melanoma, and we're so glad that it's helping us, right? I'm glad that we get to be the first ones to benefit, but also I think it's really unique that it's going to be the kind of therapy that will also benefit other cancers. It's just nice for once to have it go us first and then them. With that, Dr. Berman, thank you so much for your time today and for your expertise and just sharing your knowledge and your opinions. And I really think this is such a unique procedure. I've talked about this a lot the last few years, guys. So definitely check it out. Reach out if you have questions, and we will see you guys next time.
Thank you again.
Thank you again to our sponsors of the I Believe podcast. We've got Delcath, Aura Biosciences, Immunocore, and Castle Biosciences. Without their help and you guys sharing and subscribing to our YouTube channel and our podcast, we could not do this. So thank you again. Subscribe, find us on social media, and we'll see you guys next time.